well as the launch of the World Dengue Day itself. We've had a great first day yesterday. We'll just a quick recap of that. We had a couple of panels looking at dengue biomarkers, pathogenesis, and new horizons in terms of dengue therapeutics and diagnostics. A lot of Q&A from the audience in that particular session. We went on to have a look at trying to look at tackling and preventing dengue in terms of integrated vector control and surveillance and the role of the community in that, with a fascinating session at the end of yesterday. I'm honored and honored to be joined today by three long-standing members of our own dengue advisory group who've been pushing collectively across discipline, across sectors for a World Dengue Day for some time. I'm joined today really by Richard Allan, the CEO of the Mentor Initiative, a vast amount of experience spanning over 33 decades in terms of public health in emergency settings, and also joined today by Dr. Rachel Lowe from the London School of Hygiene and Tropical Medicine, a Dorothy Hodgkin Fellow and Assistant Professor there at the London School, looking at impacts of global environmental change on vector-borne diseases, and some actual work that's in play right now, using her work in terms of outbreak prediction. We've also then joined by Dr. Frederik Seelig, the Partnerships Manager at the Global Vector Hub, again based at the London School of Hygiene and Tropical Medicine in London. So a warm welcome to the panelists. It's a very interesting aspect of the debate. I think the first 2 days we've really seen a dominance in terms of the immunological landscape, the immunological considerations for vaccines, therapeutics, pathogenesis, treatment strategies downstream of the understanding of that pathogenesis and immune landscape. And that you could argue that and vector control are the mainstays in terms of dengue today. However, there is this existential threat posed to dengue, and it's huge. It needs its own symposia, to be absolutely honest with you, but we really did want to introduce this into this 3-day event. Some people earlier in today's sessions, in the morning session, Professor Yukti from Thailand was talking really about, there was a question asked in terms of the relationship between industrialization, rapid urbanization, migration of people, climate change into what then defines what gives the predominant serotype for dengue, and then that linked obviously to severe outcomes downstream of that. So there is definitely an interplay, and it is on the minds of people. And so we wanted to kind of bring some of this into today. So I think, it'd be a good time to kind of hand the floor over to Richard Allan, the CEO of the Mentor Initiative, to kind of give us a kind of input into emergency settings, disaster resilience, and that type of framework for dengue. So Richard, hi to you. And it's a boiling hot day here in London, so I've even taken my jacket off, it's so hot. So thank you very much for making time for this, and I'll just hand the floor over to you. So over to you, Richard.
Well, thank you very much for the invitation to come and speak today. It's an honor. I hope you can see my slides in the background.
Yeah.
I wanted to take you through what I think is a setting that helps actually set out what tools have to be able to meet in terms of requirements when they're having to be built to work in different settings. This is a disease which is evolving so fast in my lifetime, not quite 33 decades, but certainly 33 years of working in humanitarian settings. We've seen this disease take prominence in a way that no other disease has moved. And I would say that bar COVID, but a very different beast. This disease will not only spread and carry on spreading across many different contexts, but also stay with us for a very long time. So the need for finding solutions to it is really important. I direct a humanitarian aid agency. I've worked in aid for a very long time. And we have to find innovative solutions that meet the needs of people in the very challenging context that they find themselves in when the world is turned upside down, when they're displaced from home, when they're living in temporary environments, whether it be a camp or somebody else's home or a warehouse. And what we've worked to do over these this last 2 decades in the Mentor Initiative is build really effective integrated vector control programs that meet people's needs where they are, in the shelters they're in. Health service support that provides access to diagnosis and treatment for diseases where people are, but that builds capacity, not just in the emergency phase, but something that will stay around afterwards and help as people plan longer term services, hopefully as humanitarian crises wane. But in all of this, operational research is something that, perhaps unusually for an NGO, we engage in very heavily. And that's because of the inadequacy of so many of the tools that we have to work with a situation where diseases are evolving around us. We work in currently 10 different countries, and we reach 10 million people's homes every year. In fact, slightly more than 10 million people's homes. And we do so because we're privileged to have intimate access to people's homes, because that's where we can affect real disease control. And that means that when we're dealing with challenges like this, where we're having to work out how to access people that are mobile, and maybe mobile several times, because they're being chased by people with guns, because of other reasons, their houses and homes have been burnt and they've got nothing to go back to. Where we try and find new operational solutions and new tools to work with people, but in testing settings that most, I think, conventional research would like to avoid getting involved in, but which you can't avoid because a huge number of people today, over 250 million, are caught up in crises of this nature across the world. So it is a very, very large number of people affected. So finding solutions means you have to do operational research to find new tools driven by the context and challenges they're living in. So even though people may be challenging to get hold of and continuously access because of insecurity, because of their movement, that's the setting we have to find new tools to work in, and are busy doing so. But it is a setting where shelters, low education levels, completely imperfect laboratory conditions may hamper or make more challenging that research to find new tools. And where health facilities may lack some of the diagnostic capacity or ability to manage data in a way that we would prefer for nice, clean research. But nevertheless, answers have to be found that fit these very contexts. And that means tools that have to work in these contexts, not perform in nice settings, but perform in challenging settings, where they may get wet, they may get sun exposed, they may be on the move, they may get very dusty. So finding solutions that fit is a really key part of what we have to be able to do. Historically, we worked continuously through different crises, from early Liberian crises through to the tsunami, through to operations in Kenya in floods, right the way through to today, where the context itself offers a platform both for presenting new disease challenges, but also often presenting the opportunity to research and find new solutions with willing partners who are prepared to take risks in the way in which their tools have to meet standards in those settings. Sometimes the answer has to be very quick. COVID-19 threw a curveball at all of us. Our response was to find disinfection tools, the first of their kind, that would come as a kit and be deployable in any humanitarian crisis. And we found a willing partner in SC Johnson, who put a huge amount of investment and effort in to create kits that we're in the middle of evaluating in Central African Republic and Nigeria at the moment, across NGOs, across UN partners, across hundreds of health facilities. The other types of ball that's thrown at us are these slower evolving ones through the crisis, vector-borne diseases, which is what we primarily do. And I wanted to talk to you a little bit about operations where we're looking at new tools which have not yet made headlines, not yet are commercially available, but which may be real game changers. Similarv, made by a company called Sumitomo, has been around for some time. In its 2MR form, it presents something quite unique, and we're testing it in Aden in Yemen. I'll speak a little bit more about that in a minute. But also spatial repellent, something which some years back I was probably one of the largest critics because of the early stage development these tools were at. But today, these tools offer real hope for vector control, both for Aedes-borne diseases and others. And I'll give you a little example of that and how we're developing the work on it to really evaluate what possible impact these tools can have, both used separately and together in different countries, where we're heavily engaged in Yemen, in Syria, in Nigeria, and will be for the next 2 years, evaluating both spatial repellents and Symarive together, whether short-lasting or long-lasting. So the first example I'll give you is from Syria, where the country has, pre the conflict it's been experiencing that's ripped it apart across the north. In 2010, it had relatively contained but high levels of leishmaniasis, cutaneous leishmaniasis, transmitted by sandflies. And you'll see on those two maps, the dark green is where the disease used to be. The lighter the green, the less there is. And you'll see how by 2018, even with concerted efforts by our own agency, working at the rate of 4 million people's homes every year in the conflict zones, the disease has still spread and requires continuous control to stop it from being at a higher level of epidemic than it already is at. And it's currently today about 10% of where it was in 2014-15 due to good control. But it makes a fantastic position to evaluate new tools, because in this setting, we have been operating since 2013, and we have two core areas. One is supporting 180 health treatment points across the northern band of the country that's conflict affected. And the second main activity is disease prevention through indoor residual spraying and other activities in several million people's homes and shelters every year, and building up capacity as we go. That provides us with a fantastic setting in which to evaluate tools like this, where we are currently evaluating this in Syria, having trialed it in pilot phase studies in Kenya. It looks like a sheet of plastic. It's clear, it's straight through, designed by S.C. Johnson, and it has a chemical on it called transfluthrin, which is a spatial repellent. Is it clever? Now I think simplicity is really clever, because it's easy to use, it's easy to hang up. And it might be the alternative to indoor residual spraying that we've been busy reaching people's homes with very large and expensive teams for the last 7 or 8 years. And our question in Syria is not about dengue, it's about, will this work against very delicate sandflies, and will it cut cutaneous leishmaniasis? And the research is very straightforward. In many ways, we look at entomological and epidemiological outcomes, and we look at it both in camp settings and also in city settings, urban settings. We have our own entomological research teams on the ground who know what they're doing, they're well trained, and they are running this trial where we have 3 arms, both in camp settings with 3 arms and in urban settings in different parts of the country, evaluating the spatial repellent against IRS or against negative control, all the arms having access to Mentor-provided health services. And where we're uniquely able to both see how many cutaneous leishmaniasis occur in the time, but also have this intimate access into people's homes to measure the entomological impact of the tool, and also the ability of families to use it correctly and their willingness to. These are the camp settings in which we're in, and they're in the northeast. There are a lot of camps, and we've been able to work with partners on the ground to decide which camps to evaluate the tools in, which to use as in different arms. These are city areas in the northwest of Syria, where we're doing exactly the same trial to evaluate to see if this tool will equally work, well or badly, in houses compared to relatively confined shelter sizes. The whole aim of this tool is that it pushes insects away and thereby prevents people from being bitten by them when they come into their shelters at night. Sandflies behave a little like Anopheles mosquitoes that transmit malaria, i.e. they like to come into the house at night and bite you at night when you're sleeping. So pushing them away on a continuous basis is what protects people. And it's also what gives us the ability to look at this tool in application in other settings. So when we wanted to evaluate this both in its current form and a new form, which would be longer lasting, because the envelope spatial repellent has a life of about a month and then it needs to be replaced. A new tool called Mesh, which is a new generation of the same principle, is online and coming through and will be tested by us in Yemen and Nigeria, together with Sumelav 2MR by Sumitomo. And the Mesh is a really exciting tool because it has a 6-month durability and it's low cost. And it should be really easy to use because it doesn't require any clever behavior change and it doesn't require anything further than hanging it up in the correct place in a house. And the transfluthrin is effective and safe for the population to work with. The Sumelav 2MR is a little like a Pringle crisp. It's not powder, it's not liquid, it's like a crisp, and it's a plastic disc. It's treated with pyriproxyfen. And when you drop it into the bottom of a water container like this, it continues to give protection by blocking the larval life cycle and preventing adults from emerging for 6 months or perhaps even longer, maybe up to 9. And in so doing, it's the perfect tool for stopping Aedes mosquitoes in their breeding sites in households. And these are the tools that really should work against a whole range of insects, both Aedes, obviously, for the 5 diseases that we know they transmit, but also Anopheles and phlebotomin, which transmit malaria and leishmaniasis. So in these other settings that we're about to kick off in, we're looking at entomological and epidemiological impact of Mesh and Sumelav against all 3 of these insects together. We're looking at how feasible and simple and straightforward and impactful the use of Mesh and Sumelav are against Aedes mosquitoes, the larval and the adult forms, pushing them away, preventing them from breeding, but in very harsh conditions. The first of these is in Yemen, and it will have 3 different arms, and the 3 different arms will compare it against each other and against IRS as a control in Nigeria, because they will be looking for malaria as the principal outcome, and against just IEC and health services only in Yemen, where we're looking at Aedes control and dengue as the principal outcomes. So trial locations in Yemen, well, there are many camps in Yemen, in Aden city. Many of them are small. They make perfect populations in terms of being able to access in a ring fence way to carry out an evaluation of a tool like this. It takes a lot of work working with the communities because they're living in very harsh settings and you have to build up trust. That's exactly what we're doing right now, undertaking first surveys to get this started before introducing the research tools later this year or the beginning of next year, having compared it against standard disease control efforts for dengue control. And then we'll move to Borno State in Nigeria and we'll test the tool again, the same study with the same 3 arms, but in camps in the north of the country around Borno State, severely affected by conflict, and where again, the camp setting itself, whilst all of the challenges it presents are real in terms of security, they are unique populations which effectively provide quite clean environments in which to evaluate new tools. And in each of these cases, the entomological monitoring will be for Aedes, Anopheles, and sandflies. We'll be looking at abundance, we'll be looking at their indoor density as adults, their blood feeding rates, and we'll be looking at, in Nigeria, malaria, and in Aden, our work is confined to dengue and Aedes control, but they're evaluating dengue is a much greater challenge because of lack of good diagnostics in the health system. So much will be focused on the vectors themselves. But this last part of the study work, which is making sure that populations can accept and are willing to accept these two types of very novel tool, use them and use them reliably, and that under the conditions which I've described, which are very harsh, that they'll work, and that they'll work durably over the sort of timeframes that we need to make a real difference to people's lives, which is 6 months with an easy switchover for a new round of the same tools. If they do work, then in fact, they will have an enormous impact by eliminating the need for some of the much more expensive and much heavier and perhaps sometimes much less effective approaches to controlling dengue fever and some of the other diseases too, like malaria that we work with. But where dengue is new, the challenges are greatest because we've got the least global experience in these sort of settings for controlling it. And where again, the tools we've been using have been demanding to use, demanding to gain acceptance for because of the nature of them, tackling water containers where the mosquito breeds, and where everything we can do to create innovative solutions that fit the really challenging living and shelter contexts that most vulnerable people find themselves in, or even the Southern French living context, where people find themselves in a totally different environment, but again, the tools have to fit. And tools that people can use themselves at household level that don't require vast fleets of humanitarian aid workers and teams to deliver them. And where being easy to use, it's matched by being effective and continue to work well, even in the toughest conditions. And similar to MR, envelope and mesh may truly be real game changers, both in what we do for dengue control and other Aedes-borne diseases, and beyond into cutaneous leishmaniasis and malaria as well. So thank you very much.